Hi, my name's Peter Moles. I'm a registered nurse at Wollongong Hospital. I work in the emergency department there. I've been there for more than 10 years, let's say. And recently I've become involved with a project around the management of hip fractures. So that's been my latest interest, is in project management and implementation. So I've had the chance to work on this project. The last time Wollongong was able to present to the Australian-New Zealand Hip Fracture Registry, James spoke about the power of leverage and using data to improve things across the Illawarra-Shoalhaven district. James spoke about improving the length of stay in ED, time to theatre, and James left with a promise that when he came back next time, he would make Wollongong or the Illawarra-Shoalhaven the best performing district in the Australia and New Zealand. You certainly couldn't say that James isn't ambitious. So where are we now? Well, James was right in a lot of the things that we have achieved. If you look at our data, from 2017, when we started collecting data and started using the Australian-New Zealand Hip Fracture Registry to improve our hip fracture patients and our management of patients in ED, we've seen some big improvements in our time in ED. From our previous longest stay of 46 hours, we've got that down to less than 24 hours, which is a key KPI for the ED, and a much needed improvement for the journeys of hip fracture patients. We've seen the average length of stay decrease ever so slightly, but we're moving in the right direction. Our time to surgery increased dramatically, from an average of 47 hours down to an average of 32. And if you have a look at those longest stays, from 10 days waiting for an operation on the hip down to 2-3 days, we've improved our time to surgery dramatically. And that took a lot of work. We'll talk about that in a minute. Our acute length of stay has decreased slightly, and our hospital length of stay has decreased across the days as well. So we've seen improvements across a lot of areas, but as anybody knows, working on these type of projects, it never ends. There's always more to do. So we've managed to achieve these things through a hip fracture committee that's convened monthly by the surgical CNC, who unfortunately couldn't be here today to present this. The hip fracture committee meets monthly, and we look at the breadth of care from ED to follow-up at 30 or 120 days. We include a lot of people in this committee. There's representatives from emergency, the CNC, RNs like myself. There's orthopaedic representatives, a registrar, the head of department, geriatrics. We've got a geriatrician involved, John McKenzie, who gave me that quote up the top there very early in my project that I'll talk about in a minute. He said, if you can get hip fractures right, your whole hospital is working well. And I'll circle back to that in a minute. We've got representatives from surgery. Obviously, this is convened by the surgical CNC, as I said, and the surgical stream manager comes along. Anaesthetics and their head of department, the acute pain service at our hospital is involved. We have physiotherapists, both from the acute wards and the rehab. And then when I've started my project, now I know I'm on dangerous territory because I'm bound to forget some people, but I definitely shouldn't forget the orthopaedic ward, the nurse manager and the CNE that come along. And then we've included a bunch of other people with the project that I've been working on as well. So data managers come along to these things, radiology, the dietitians have been kicking down the door to be involved with these patients. I've met with aged services, dementia and delirium, geriatric CNCs and discharge planners. If you look at John's quote up in the top corner, I certainly feel across my project over the last 6 or 9 months that I felt that I've met with most of the hospital, in fact. So the project that I've actually been working on is called eHIP, and it's a notification and bundle of care for hip fracture patients, particularly at Wollongong Hospital at the moment, but this will eventually roll out across the district. Now, we've got a bunch of bundle of cares that we use for different presentations in the ED. And the idea is to get people involved early, to get the right care to the right patients. So how this project works is that we've got a particular focus on getting x-rays early for patients with minimal movement, early pain assessment and management. We've included nurses in training to do fasciileac blocks. So more patients are getting early fasciileac block. And what the actual project is we notify from triage when a patient with a hip fracture is identified. And that notification goes out both via our pager system with Switch, and there's a consult on EMR. And it notifies our anaesthetics team, our acute pain service, orthopedics, orthogeriatrics, physiotherapists, dietitians, the bed managers, radiology, surgical bookings. And again, I'm probably forgetting somebody there, but it notifies people that will be involved in the breadth of these patients' care nice and early, pretty much in the first 30 minutes that they arrive in the emergency department. Within this project, I've been able to focus, because I'm ED based, on some of the ED management, and we're trying to improve our preoperative cognitive assessments and our after hours medical review to start that geriatric process. Now, a lot of my project has been based on making sure that this is an effective intervention and that it's sustainable as well. That's one of the most important things with projects like this. Now, I've had great support from this, obviously, the local people involved, but also the Australian New Zealand Hip Fracture Registry, the Illawarra Health and Medical Research Institute, and the New South Wales ACI have provided funding and support across this journey. Now, my project to try and impact the effectiveness and sustainability, I've used what's on the slide at the moment, the theoretical domains framework. Now, what this has done is this framework identifies 14 behaviours that will impact the effectiveness of an intervention and sustainability. An example is a previous project that we did on patients with chest injuries and the use of high flow nasal prongs. So in something like that, you don't need to consider all 14 of those domains. In that particular project, we consider the skills, the knowledge, memory, reinforcement, and resources. The framework acknowledges that not everybody is the same. Some people will use the high flow nasal prongs in that project because they've been educated and they acknowledge that that's best practice for the patient. Others won't respond to that as well, and they might need some behavioural regulation or a little bit of belief about the consequences if they don't use them. So that's how this framework has worked, and that's where I've spent a lot of my time, is making sure that this implementation is going to be sustainable and effective. So what is it that we're trying to achieve? Well, we are trying to achieve better care for our patients, appropriate care, best care. And how we're going to reflect on that is through the Australian New Zealand Hip Fracture Registry, the reports, the data collected from that. Particularly in this project, we'd like to improve our pain management and assessment, our length of stay in ED, hopefully will further improve our time to surgery. Our orthogeriatric reviews and medical assessments. We'd like to cohort these patients on our specialist orthopedic ward nice and early. And we're looking at improving our preoperative cognitive assessment in ED by rolling that out to all nurses. This is not something we've previously done in our emergency department. So we're hoping that all of these improvements will be reflected in our data in the next 12 months by the next report, hopefully. So where to now? Well, we've rolled out this project, but the Hip Fracture Committee continues to meet monthly. I've done a small project, a small contribution to the continuing excellence in the care of hip fracture patients. But we'll come back and we'll take a look at the data and we'll develop our next focus, whether that be the ward-based, the follow-up, or somewhere else. Right now, we're looking at our data collection and making sure that it's perfect, that we're reflecting accurately what's happening with these patients in their journey across the hospital systems and across the district. So thank you for listening. There's a little photo of some of our group. We couldn't get them all together via Zoom, but there's some very important people in that photo. There's some email addresses. I'm Peter and I did the eHIP project, if anybody wants to know about that. Our surgical CNC convenes these meetings and does a lot of work with the hip fracture patients. That's Lauren. The orthogeriatrician involved is John McKenzie, who's excellent and passionate about this as a project. And if anybody wants to know anything further about the theoretical domains framework, Professor Kate Curtis, who is the CNC in ED across the Illawarra Shoalhaven district, is an expert at that. So thank you, everyone.